In our previous section on scoliosis, we talked about the strategies and the techniques for mobility. Mobility for a C-curve, mobility for a S-curve. What we want to talk about today is the strategies and the techniques as they relate to stability, or what some people might say, strengthening the new path, or trying to correct the curve. Interestingly enough, if we take a look at our strategies that we started with, based on our principles that we started with, our strategies allow us to understand how to get to stability the same way our strategies allowed us to get to mobility. Mobility is creating the new path. Stability is reinforcing that path. One of the interesting things is the understanding of the definition of stability. It's not a fixed posture. It's not stabilized. It's not as in the lack of motion. Stability literally means, in a functional world, motion under control, or motion that the body likes to go get as a resource, or in our context, new motion in a new path that the body feels confident in utilizing, and it feels more confident in utilizing that new path than it even does the old path that it kind of dug out on its own. And so when we understand stability, we're going to understand huge strategies and what the techniques look like. And this is where this gets even more exciting, because there's a lot of different things we can do to create stability. Creating that new path, getting that posture, getting that opportunity, there's just so much we can do in kind of to groove out that new path in all three dimensions. But once we do that, there's a number of ways that we want to stimulate the body in order to utilize that path. Again, we're going to look at gravity, ground reaction, force, and mass and momentum. We have to use movement. We have to use the upright posture, understanding that we have a neuromusculoskeletal problem here. We know we're going to have to approach this 3D, and we know we're going to have strategies, certainly for the frontal and transverse planes, but always be aware of what we're doing in the sagittal plane, knowing that the sagittal plane could serve as a bailout plane, and we're not wanting a bailout plane. Drivers in this case are going to stay the same. We're going to use the eyes, we're going to use the head, we're going to use the pelvis. But the two main drivers we're going to use today are the two most authentic drivers in the body, and that's the two hands and the 2 feet. Later on, in subsequent ways and approaches to scoliosis, we can talk about using the head and the eyes as a driver, and using the pelvis, and using the trunk itself as a driver. But right now, it's so easy to say, hands, can you give me a top-down approach? And feet, can you give me a bottom-up approach? It's a great way to start, and it's a great way to continue our approach to creating stability of this new path, this new curve that we're creating for this amazing individual. Again, it has to be subconscious. We got to kind of make it a fun exercise, a fun movement, so we're not asking the person to consciously try to do anything, hold any muscles, or try to move any bones, or try to stimulate it. We just want them to take your hand here, and take your hand here, and take your foot here, and let the rest do its work, understanding our chain reaction biomechanics. Again, probably the biggest thing we have to really appreciate and respect is the path of least resistance. We're going to see that putting this together isn't as simple as just doing an exercise. It's saying, if I do that exercise, what will the body do to try to bail out? Again, we're always asking ourselves, if I ask the body to do that which it doesn't want to do, what is it going to want to do? And it's going to want to bail out. So you'll see a lot of bailout strategies, understanding the path of least resistance. Again, we got to appreciate we're trying to develop a new type 1 movement. They have a type 1 deformity. We're literally trying to create a new movement the other way, in the frontal plane, the other way in the transverse plane, and certainly we want to complement what's happening in the sagittal plane. In mobility, we understood that what we do for a C-curve to the right is exactly what we're going to do for a C-curve to the left, just mirrored. So again, put this in your mind's eye right now. We're going to talk about a right C-curve, but what we're going to do for a right C-curve now, if you simply say, well, what would I do for a left C-curve, the apex to the left, the rotation to the left, the answer is just flip everything. Just mirror everything. We're going to do top down, mirror everything. We're going to do bottom up. The strategy for an S-curve is very, very easy. An S curve is either a right curve in the upper segment to the right and the lower segment to the left, or it's the opposite of that. We have this. So again, a right curve, we're going to do what you're going to see right now for strengthening, for stability, top down. But what we would do bottom up is what we would do for the mirror image of a C curve to the left. So if I had a C curve just to the left, it's going to be the mirror image of what you're going to see. Let's do right now the C curve to the right. So our bottom-up approach will be that mirror bottom-up approach. Obviously, an S curve where we go to the left in the upper curve and to the right in the lower curve. This right approach, the bottom-up, is what you're going to see right now because it's the right C curve approach bottom-up. But top-down, it would be the mirror image because we have a left curve. Got to keep that in mind to understand that we're going to attack this thing top-down, bottom-up, and depends upon if we have a C curve or if we have an S curve. C curves, you're going to see that right now, but an S curve is literally two C curves, and obviously bottom-up, you're going to do the image of what that C curve is bottom here and the C curve up here. That's going to be, again, quite obvious as we go into our stability as it was when we did our mobility. Now, understanding that we're going to look for success, we're going to find out where our patient is successful, and we're going to build upon that, and then we're going to tweak and progress. With stability, though, we're after strengthening. One of the first things we'll do in strength, and one of the things we'll keep constant, is understanding that just controlling body weight against ground reaction force, gravity, mass, and momentum is a key thing. But in this particular section, you're going to see us add a little bit of load so we proprioceptively can really stimulate the body and say, here's what we're after, body. Here's what we really want you to do. And again, we're going to start with very light loads and depend upon the success of our patient. One of the tweaks would be to gradually increase the intensity, increase the weight of that particular load. And so we'll see that in a kind of an obvious approach. Now, another big strategy you'll see us employ is that initially, to teach our patient, we're just going to use one driver at a time. But as we use one driver at a time, you're going to see that we're going to pre-position the other three drivers. Very important. So if I was going to use one driver at a time, I would need to understand that if I'm going to try to go after, let's say, the frontal plane, utilizing my left hand with the weight, that if I'm moving that the body's going to say, well, yeah, I can do that, but in order to do that, I'm going to bail out top down in the transverse plane, and bottom up, it's going to bail out not only in the frontal plane, but also the transverse plane. So yeah, we got a pretty good exercise going on there, but we got to prevent the bailout. So strategy one, when we use one driver, we're going to fix the other three drivers to pre-position the body, to tell the body, this is the position we want you to ultimately be in when you go through this particular motion. You'll see that it'll be quite obvious. Then what you'll see is a strategy where we'll use two drivers, the two top drivers and the two bottom drivers. And then you'll say, well, I bet when you use the two top drivers, you'll pre-position the two lower drivers so it can't bail out, correct? And when you use the two bottom drivers, you're going to say, I bet you're going to pre-position the top drivers so the spine can't bail out, correct? Big strategy here. We just can't simply say, hey, do this, and kind of expect the body to find that new path, because if it's got another part of the river it wants to go to, it will, unless we go, nope, we're going to put literally blocks up to that part of the river, and we're going to make it very comfortable and inviting to be in this part of the river in order to create that new path. Perhaps the most significant strategy is understanding that proprioceptively muscles get activated by going through motion and then eccentrically decelerating a motion and then concentrically producing the motion. The easiest way to see that is if somebody's kyphotic. If somebody's kind of in a sagittal plane kyphotic, certainly we ultimately want them to stand up straight, but they're proving to us I can't do that right now. So if we understand that first of all, we would probably go to a frontal plane driver and then a transverse plane driver, but if we're going after the sagittal plane in this case, we know that what we're going to do is we're going to load the body into the deformity. Key, write that down, memorize that one. In stability and in strength, we're going to load the body into the deformity. So if I was going to stimulate the body to say, I don't like you here, I want you here, the way I do that is I load you, and I load you more into the deformity. So I turn on more in the lower extremities, I turn on more in the hips, I turn on more in the core, and immediately proprioceptively, the motion turns on proprioceptors. The proprioceptors say, hey, decelerate that, and concentrically go through that, and all of a sudden, I can begin to correct the kyphosis. We're literally going to use that strategy to correct the frontal plane curve and the transverse plane curve while all the while being very respectful of what's going on in the sagittal plane. We are going after a C curve to the right, apex to the right. I'll simulate that. I'm laterally flexed left. Basically, I have, relatively speaking, it seems like my pelvis is a little higher on the left, lower on the right. My left shoulder's down on the left, up on the right, and you can imagine a C curve. We've already done our mobility to clear the new path. Now we're going to say we're going to proprioceptively load you and to allow you step by step the strength in order to facilitate the ability to take advantage of that new path. As indicated, we're going to start with a one-hand driver. In this case, we're going after the frontal plane. And in this case, going after the frontal plane, we're going to use our left hand. Big strategy, as you remember. We're going to use a weight in this case because of gravity and what gravity does to the frontal plane, and we're going to load into the deformity. So again, I'm standing with my back to you. I'm going to exaggerate the curve. If this is the curve, literally I'm going to say, okay, I've cleaned up this motion and created new mobility, but now I'm going to pre-position the other three drivers. In other words, I'm going to pre-position the spine in all three planes of motion. I have to have 4 points of attachment to do that. In other words, if you have to have 4 contact points so you don't have a bailout in order to facilitate that. So one contact point is going to be the moving weight, and the other 3 are going to be utilizing the system we've already designed in their bedroom. Again, we're going to load into the deformity. It's really this simple. We're going to understand that I'm going to, again, get on my elevated pad that I've already decided that I want it this high. Again, it immediately makes me feel like I want to go this way, so this is a correction. I'm going to take my left foot and move it forward, which rotates the pelvis forward, or relatively speaking, rotates the ribs to the left. That's what I want. And I want my hand to facilitate that rotation as well, top down. So I'm going to grab onto my bar, and I have the weight here, and I'm going to simply use a very, very light weight, and I'm going to see if my patient can take the weight, and when they load it, does it increase the curve momentarily, and can they explode through it? Does it increase the curve momentarily, and can they explode through it? Because right here, interestingly enough, this position of the hand, this position of the foot, this position of the foot is saying, boy, I don't even like going into that curve now. You're telling me what I chose as the curve that I want you to have, I really don't like. And then when you take the weight and you say, go into it, but then all of a sudden explode out, all of a sudden I feel all the muscles of my hips, my legs, my trunk saying, oh, okay, that's what you want. So it's a quick kind of hitter and load. Now, one of the big tweaks we use very early on with the lightweight is speed. Just getting it over there, and again, not only explode up, but kind of explode back to get that extension. We can kind of let it throw us into flexion, but kind of throw us back and up into the extension. So it actually is, again, one of those that when you come out of it and put the weight down, immediately you feel drawn to having a lateral flexion to the right, because immediately, as soon as your body feels that lateral flexion to the left, the proprioceptors in the entire body say, I felt that, I decelerate that, I choose to bring you the other way, and all of a sudden we say, wow, that's a really good first step in creating a stability exercise in order to facilitate what I want in the frontal plane, top down, for a C curve that has its apex to the right with the lateral flexion to the left. The next thing we're going to do is we'll put this weight down, and we're going to load the transverse plane, which we choose to use bungee cords for, simply because Bungee is a nice way to load the transverse plane. We could certainly use massive momentum, but with the massive momentum, the weight's also pulling us down in the sagittal plane and the frontal plane. So to really give the body the information we want, you'll see us use a bungee cord in order to load the curve in the transverse plane while the other three drivers are positioned in order to facilitate the position of the spine to prevent bailing out. The tool we choose to use to load the transverse plane for our stability, for creating the reaction that we want in the spine, is a bungee cord. Not just a kind of a cheap short bungee cord, but a fairly long bungee cord. We want tension here, we want tension here. We don't want too much tension. If it's a short one, it becomes amplifotonic. In other words, the further away you get from the attachment, it gets too much. We want just a nice kind of a flow of resistance in the transverse plane. Now again, you're already anticipating what we're going to do with this bungee cord. Like we did with the free weight, we're going to use the bungee cord to load me more into my deformity. Now remember, I have a C curve. A C curve with lateral flexion to the right, which is a right C curve. I'm rotated to the right. So therefore, using my right hand, if I wanted to make that curve worse, I would simply say right hand, rotate the spine, rotate those ribs even more to the right, and you'd say, that's going to make the curve worse. That's exactly what we want to do. Because if I can make the curve worse, at the same time load and explode, and let the explode then make it better, or let the motion turn on the proprioceptors to decelerate the deformity and let the body automatically, subconsciously come out of the deformity, I have myself exactly what I want. So we're going to pre-position the other three drivers. And in order to do this, we're going to use our same setup, but we're going to need to rotate a little bit. We have our bungee hooked up, and again, if this is my daughter, it's going to be her bedroom. We're going to hook it up to an eye bolt somewhere in the bedroom in order that I can have this long bungee cord that she can grab on very easily and effectively and go through these exercises. Here's all that she needs to be able to do. I'm going to pre-position the right foot to elevate the pelvis on the right to correct the curve according to mobility. I'm going to correct the curve according to mobility by bringing my left leg over so the pelvis is now rotated to the right. Relatively speaking, the rib cage now is rotated to the left compared to the pelvis. I'm going to take my left hand and load the curve mobility-wise in the frontal plane for the correction. So I have a right foot correction, a left foot correction, a left hand correction, and I have a bungee cord that's making my curve worse dynamically. So this bungee cord's pulling me. If I'm normally here, it's going to pull me into more right rotation. Soon as I feel that stimulus, all I need to do is cross over and create the reaction I want. Load and explode, load and explode, load and explode. And again, as that loads and explodes, if my body would want to laterally flex to the left, which it probably would if I wasn't hanging on, it can't because I'm hanging on. If my pelvis would want to rotate back, it can't because my foot's on the ground. And if this side of the pelvis would want to rotate down and this side rotate up, it can't because of the platform I'm on. So I have this almost perfect, it looks like a simple, easy exercise, but in reality, it's an amazingly well thought out exercise relative to what I want to accomplish. I'm loading into the deformity in the transverse plane, pre-positioning top down the spine and bottom up the spine, and saying, in addition to what we just did with the free weight, load and explode, we're going to take this bungee cord and we're going to load and explode and turn on the hip muscles, turn on the core muscles, even turn on the shoulder and neck muscles in order to say, when you feel yourself go this way, which is your natural way to go now because you have the scoliosis, we want the proprioceptors to say, you know, that's not what I want. I like getting loaded and exploding the other way. I like the feel of this and I like the feel of this, and immediately the scoliotic curve goes, wait a minute, I thought we liked that. And we're saying, no, we're going to outthink you. You think you like that, and with this rotation, we want that with this rotation. We want to create this new path. And again, what's tricky about this new path, it's just not a new path. It's a new path in the opposite direction. As you can think, if I have a stream going down the mountain, And if I just want to take a path and I just want to take it a little bit this way, I can. But if the path normally goes east and I want this path now to go left, I got to create all kinds of reasons why the body in this case, the water in this case, the spine in this case, every part of the body, the chain reaction says, I'm no longer excited about going to that path of least resistance. I want to go through this new path of least resistance that's being built for me through the nerves and through the muscles and through the bones in a neuromusculoskeletal way, in a very applied functional science way. Now, you already know where we're going next. We're going to combine the two upper extremity drivers together in order to then create a frontal plane, transverse plane, and even sagittal plane reaction while we're pre-positioning the lower extremities. The beauty and the wisdom of applied functional science is the ability to understand mentally the principles and the strategies to get us to the techniques. When we finally see the techniques, we go, well, of course we would do that. What the beauty and wisdom really reveal is that a lot of techniques we've done for things, especially scoliosis, and many, many, many other abnormalities, have just flat out been wrong simply because they weren't built upon the truth of human movement, or what we call applied functional science. So when we see my right foot on something and my left foot pre-positioned to create a reaction in the pelvis and the transverse and the frontal plane, and we see my one arm grabbing and decelerating a bungee cord and my other arm grabbing and decelerating a free weight, if you were just to all of a sudden log on right now and watch that, you'd go, what in the world is going on here? What are we doing? Well, if you've been following along in all the sections, you go, there's a little bit of wisdom to that. In fact, there's a lot of wisdom to that, because wisdom is taking advantage of truth. Wisdom is taking advantage of what we know to be truth and transforming it into something that's going to be meaningful for somebody else. Here's how easy it is when we combine both upper extremity dynamic drivers and pre-position the lower extremity drivers. You already know where we're going to go. Instead of having this right lateral curve with this left side relatively elevated here and the left side relatively depressed here, we're going to immediately treat the frontal plane by getting up on our platform. Immediately it makes me feel like I want to go the other way. Then we're going to say, instead of letting that pelvis go this way with relatively speaking, with the curve going to the right, we're going to move the pelvis forward with our left foot. So we're just going to position ourselves here nice and stable. We're going to let this bungee load us into the deformity of the transverse plane. Make sure we are comfortable with that exercise. And now all of a sudden, all we're going to do is say, wait, when you load me here, when you try to make this curve worse top down, when this bungee cord tries to make this curve worse, we're going to explode out of there. This is going to be a frontal plane explode. This is going to be a transverse plane explode. It's really easy. As soon as you feel that bungee cord come across, we're coming across here. And again, we can add a little sagittal plane by letting the weight go not only to the side, but a little bit front to the side. And then all of a sudden when we explode, we get into the sagittal plane extension, we get frontal plane lateral flexion to the right, and we get obviously trunk rotation to the left, which is correcting the curve. Notice though that the implements are facilitating the curve, facilitating the curve, facilitating the curve, and we're exploding out of the curve. And again, this is one of those you go, wow, I feel it down into my calf, both calves. I feel both my quads and hams working. I feel both hips working. I feel my trunk working, and I can see that this pre-position of the feet to prevent the bailout is going to be key to getting this load and explode going here top down. And we can see that again, you come off of that and you go, I'm going to do that mostly because it makes me feel better. If we had a pre-position, predestination, kind of pathway of a lateral curve to the left with rotation to the right, and we just simply did that exercise, you'll come out of it and your body immediately go, wow, I don't like that. As soon as I feel that, I want to neurologically get out of that. I don't like that. I neurologically want to get out of that. And all of a sudden, top down, gravity is now teaching us a new path. Again, now we're going to our next strategy where we're going to say, let's go after the bottom-up drivers so we can use ground reaction force and the legs themselves to get into the lower extremities and the hips and the core. But in order to do that, we have to understand we're dealing right now with a C-curve to the right. We're going to have to pre-position the hands and then pre-position each of the lower extremities while we're working on the other lower extremity as a driver. So now again, we're dynamically going to create stability in the curve, which means allow the curve the mobility that we've already given it, but a ability to utilize that mobility and become stable, functionally utilize that motion. So we said, okay, we did a top-down approach. Now we're going to do a bottom-up approach. And the bottom-up approach, again, is going to be a frontal plane approach and a transverse plane approach with an appreciation of what's happening in the sagittal plane. If we're going to use one driver, we're going to use a foot driver right now, we have to then pre-position the other three drivers in the position of mobility that we desire, because if not, we know that the body will bail out. We just can't simply say, here, do this exercise, because as soon as the body does it, it'll say, well, you're creating one of the planes bottom-up path that you want, but if you allow me to go where I want in the other ones, I will, and I'll reinforce the path of least resistance. When I look at the history of previous attempts at treating scoliosis, I think that's where we failed miserably. We didn't understand that we load into the deformity, we didn't understand mobility, we didn't understand path of least resistance, and we didn't understand that we got to attack all three planes, top down and bottom up, all at the same time, or else the body, in its own unique wisdom, will bail out and say, I'm just going to make it easy on myself, so what you're after, you're not going to get. We have to create the chain reaction. We have to create the environment so we get exactly what we want to get. Here's how easy this is. On this case, we're going to take our platform and we're going to put it on the other side. So as you remember before, when the platform was on the right side, it elevated the spine, which immediately, if I corrected myself, it forced me into a lateral curve to the right. We're trying to treat a lateral curve to the left. So if I said, well, I want to create an opportunity where this frontal plane is forced to go into more of a curve, all I have to do is say, well, I'm going to stand on this platform with my left foot, and if I just let my leg go down here, you can see that that reinforces this angle of the pelvis. It reinforces the lateral flexion to the right, and it reinforces the rotation of my rib hump to the right. So lateral flexion of the body to the left with the rotation to the right. So I'm going to say, not going to let that happen top down. I already know how to not let that happen top down. I'm going to simply go, I am going to go lateral flexion here to the bar that's already been preset. Going to beat up the curve there, create mobility. I'm going to get the curve here, so I'm going to get it in the transverse plane. I'm going to get nice and close, and then I'm going to say, now if I'm going to load this pelvis and explode it in the frontal plane with the use of a cuff weight, with the use of a free weight on the ankle, I also have to realize that I want to pre-position my left leg. So I'm going to bring my book up and around, position it right here, get it pre-positioned, pre-position my right hand here, my left hand here. All we're simply going to do is let the weight, let gravity increase the frontal plane curve bottom up, and I'm going to decrease it. Increase it, I'm going to decrease it. All I have to do is just step up on this, and immediately I feel a ton going on my left lower extremity, a lot going on in my core, a lot going in my kind of everything through my back and even my shoulders. But again, if my body wants to bail out, as I'm loading into the deformity and coming out of that and giving the body not only the mobility from both hands and the feet, but the stability by loading into the curve and coming out, if my body wanted to go back into its old path, it can't. It just simply can't. So again, this is kind of neat because it's just a neat feel. And as soon as you take that weight off, immediately you feel like, wait a minute, it feels like this leg, this hip wants to go higher. I've given this leg more stability to allow that to go higher, which might even be proprioceptively what goes on with the curve sometimes, a kind of a dominance of the hips. And I've done my top-down stuff, and so immediately it's almost like I'm creating this whole new type 1 path with lateral flexion to the right, top-down, and now bottom-up with rotation to the left, which is exactly opposite of the scoliotic curve that we're treating. That's the whole point. You already know where we're going next. The next thing we're going to do is we're going to say, we're going after that transverse plane. I bet you anything you're going to use a bungee cord again. I bet you anything you're going to put the bungee cord around one of the ankles, and I bet you anything you're going to actually facilitate a reaction that you want in order to create the rotation that you want bottom up while you pre-position the other side. Okay, so I got a C-curve. C-curve means I'm laterally flexed to the left. The C-curve with the apex to the right has a rib hump to the right, which means my ribs are posterior, relatively speaking. My shoulders are forward, relatively speaking. My pelvis on this right side is forward. So when the pelvis on the left side is back, the shoulders are back, it reinforces the curve. I'm after using the foot driver in the transverse plane to facilitate the stability aspect of getting this curve to be comfortable with this new path. Therefore, you already know the strategy. Pre-position the left hand and the right hand in the frontal and transverse plane into the motion and hold that position that I want this new curve to appreciate. Same thing with the left side. We're going to use the left side again to elevate this pelvis in order to pre-position this curve bottom up in the frontal plane, and I'm going to use my left foot in order to create the reaction. In this case, we're going to use a bungee cord. Again, long bungee cord. And part of what we do as the AFS practitioners is to advise on where this bungee cord somewhere in the room needs to be attached. So not only do we help our patients with the bars and with the platforms they're going to get on, but the long bungee cords and basically the ways to approach this. Now, if you add up all this equipment, it literally is less than 30 or 40 bucks. Definitely worth a lifetime of trying to successfully create a new path for someone with scoliosis. So it's going to get easy again. We're going to pre-position the right foot. We're going to elevate the pelvis in the frontal plane. We're going to pre-position the right hand to create rotation to the left. We're going to take the left hand and pre-position the frontal plane. And immediately I feel this cord pulling me this way. And you're going to say, wait a minute, that cord's pulling you into the deformity. Exactly. It's pulling my pelvis into left rotation, which relatively means my thoracic spine, that apex of the curve, is in the right rotation, which reinforces the curve. I want to do that because what I'm going to tell everything in my body is I don't want that. I want to decelerate that. So pre-position, I'm elevated here, let it go, and then I pull it across. I bring it here, I pull it across, and I literally try to take my foot from back around the corner to the front, and you can see when I do that, the pelvis goes from here all the way around here, and I'm strengthening all of the movements facilitated by the proprioceptors that would want the body to want to go in that direction. So again, I'm going to go here, and I'm going to load and explode, load and explode, load and explode. Now, again, when we break this down, it looks very easy. When we really break it down for the patient, it's easy for them to do, but they're going to need our encouragement. They're going to need our guidance. They're going to need to know kind of how much tension we want. We don't want to over-tense this. We just want to create a little bit of reaction with our weight in our hand, with our weight on our ankle, with the tension of the bungee cords to facilitate the load into the deformity and the explode out. Now, the beauty in this one is pre-positioning the hands and the foot creates a lot of what we call reaction from the ground into the right hip. You're going to see when we go to the next segment, we're going to take advantage again of elevating the left side, now ground reaction force on the left side, and using the right foot not only as the driver in the transverse plane, but the driver in the frontal plane. We're going to combine the two, knowing that we really strengthen this right side by going just with the driver in the transverse plane, but now when I elevate the other side, feed into the deformity with the cuff weight, and then feed into the deformity with the bungee cord, all of a sudden I'm going to be able to load and explode, load into the deformity in the frontal and transverse, and come out of it while I'm pre-positioning again the hands so I can't bail out through the top down. When that spine all of a sudden gets forced by the bungee and gets forced by the weight, and all of a sudden all my proprioceptors say, let's not let that happen, let's pull it back. When all those muscles take over, the body still is going to look for a path of least resistance if we don't have those hands pre-positioned or do something which you're going to see in what we call putting it all together, then it's going to bail out, and we're not going to get exactly the chain reaction that we are desiring. What's great about this technique as we look at a double driver, but double driver being driven not only by the position and the elevation of the left leg, but basically a double driver on the right foot. In other words, we're going to drive the right foot down with a cuff weight, and we're going to drive the right foot over and across with a bungee cord. Now let's think through this again. The hands are going to be pre-positioned, so we're going to fight this curve by doing this, pre-position. We're going to fight this curve by doing this. You already know that's going to happen top down. Bottom up, you're going to say, well, we want to add to this pelvic obliquity in the frontal plane, and so you have to explode up. So it looks like, again, you're going to have to put your left foot up on something. I'll put my left foot up on a book, the elevation that we think is appropriate, and again, that's something we have to evaluate. Is it 1 inch, 1.5 inch, 2 inches? And once we do that, suggest to get a nice strong platform and with a little bit of non-slippage stuff on it, and we realize that we're going to get this thing going on, but at the same time we realize that to add to the deformity, I got to get the pelvis to rotate to the left because the ribs are rotated right. So I got to somehow get something to pull my pelvis that way. Well, it's easy. The bungee cord will pull me that way. So pre-position the hands, weight on the right ankle, bungee on the right ankle. Right foot's going to be the driver. Left foot's going to be kind of a driver. The nice thing is a lot of the force is going through the left lower extremity into the left hip, into the core. We just got done with the right hip taking, so to speak, the hip, getting a lot of strengthening to actually improve this new path. And it looks a lot like this. So I'm going to get, again, pre-position here. So now I'm adding to the deformity. So if I elevate this, I'm going to say, go into the deformity, come out, go into the deformity, come out. And I'm going to simply say, transverse plane hand, pre-position top down here, frontal plane hand, pre-position top down here, foot, go here, bungee cord's pulling me that way. I'll give a little more tension by pulling over a little bit on my pad. And so it pulls me here, pulls me into deformity, I get out of the deformity. Pulls me into deformity, I get out of the deformity. But not only does it pull me into deformity, but it pulls me down. So if you took a look at me, right now I'm loading into this pelvis being elevated on the left, which is loading into the deformity. I want that to happen because I want the proprioceptors to say, wait a minute, with that weight on there, it's stimulating you to decelerate that, come out of that, and come up and come out of that. So it's kind of touch, come up and out. 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 And again, our responsibility as a clinician is, of course, have our patient's shirt off and look and see if the spine's doing what we want the spine to do. We should see it load into the deformity, and when they explode, our eyes should get big and say, whoa, that's exactly what I'm after on the explode. And the pre-position of the hand should be, well, you can go a little more. I want a little more frontal plane load, or I want a little more transverse plane load. And that's a lot of what we're going to be coaching, a lot of what we're going to be training, a lot of it we're going to be rehabilitating with our mind in order to properly teach our patients on what to do. So we've already gone through stability training, one-hand driver, two-hand driver, one-leg driver, and literally a two-driver with one leg, or what we would call a two-leg driver, pre-positioning the other drivers that aren't being driven. And again, we're driving into the deformity. Can we get to the point where with some balancing and with some activity, our client literally can do this kind of without pre-positioning themselves and literally getting all four drivers going at the same time? Well, logic would say go and maybe pre-position the hand and then just do the frontal plane driver, pre-position the other hand and do the transverse plane driver. But we'll kind of see here. And then also kind of pre-position the hands and just do the one hand and the 2 feet as a driver. But let's take a peek at what looks like when we finally get a couple weeks down this, where we're literally dancing in this thing, and we're using 2 bungee cords, and we're using a cuff weight, and we're using a dumbbell in order to facilitate the 4-driver system, in order to tell the spine, we're going to load you, we're going to let you kind of get a little bit into your deformity in all 3 planes of motion, but we're going to explode out of it, and we're going to teach you, this is our new 3D scoliosis stance, which is going to be a dance to get us out of that scoliotic curve. So if you fast forward and saw what we're going to do next, you would say, are you crazy? And we would say to an applied functional scientist, yeah, they're kind of crazy like a fox. Because when you see this all put together, and especially when you see dynamically what it does to the entire body in all three planes of motion, to feed the spine the information we want it to be fed in order to get it confident in a new path, it's kind of like crazy like a fox because there's a lot of wisdom in it. And what's fun is, if our patient is like me, they get bored easy, kind of doing a couple of the exercises single-handed, double-handed, single-footed, double-footed, and all of a sudden saying, you know, I really want you to kind of combine these, but maybe every third or fourth day, let's turn the music on and let's go at it, and let's use all four drivers. So I got a free weight in my hand. It's going to be in my left hand in just a second. I got a free weight around my right ankle. I got a bungee cord around my right ankle. I'm going to elevate my left foot in order to create the reaction that I want, and therefore I have a driver on that left foot side. And then I'm going to have a bungee cord in my right hand in the transverse plane. Now what's neat is, the bungee cord's properly positioned, they kind of create a little bit inherent stability for me, so it makes this exercise a lot easier to do than it looks. Now, if a mid-60-year-old guy can do it, our kids can do it, especially if we take them through the movement literacy, the progressions of learning how to do this. Plus, this one becomes fun because when you come out of it, you feel like every part of your body has been told, we're not happy with the old scoliosis path. We're going to give ourselves a new path to inhibit that in order to facilitate opportunities for the type 1 motion in the opposite direction. Now again, before I show you this one, realize that if you're saying, well, wait a minute, I don't have a C curve with the apex to the right, with the lateral flexion to the left, mine goes to the right. All you have to do is mirror these. And if you're saying, now wait a minute, I have an S curve, a C curve up top with the apex to the right, and a curve to the left, obviously a compensatory curve. All you do is top down, do what we're doing here with the C curve, the right C curve, and you'll just flip what we're doing bottom up for your S curve, for your bottom C curve on the S curve. And then from that you go, if you have the opposite, if I have a curve with the apex to the left up top, apex to the right bottom, I just flip that. So it becomes very, very easy to apply this to either C curves or either of the S curves. Again, here's how easy this is, and again, for this one, this is a fun one. A driver on basically the left side that's going to take my left pelvis and drive it up, which says if I just let this go down with the weight, it's driving me to deformity. A bungee cord that drives me with rotation to the left drives me into deformity. A bungee cord that drives me into the deformity top down in my thoracic spine. A driver here that drives me into my deformity. If I just let this happen, this is just going to reinforce the curve. If I just sit here dormantly, statically, and let this happen, big curve, big curve, big curve, more rotation, that's not what we want. Let it feed. Start with the foot, simply touch, elevate. When we explode the hand. Go here, explode it. Go here, explode. Here, get here, explode. Get here, explode, and then throw the boom, explode. Here, explode. Here, explode. And again, we'll want a nice stable surface here. This is spinning on me a little bit. But again, this is going here and down. Rotating down. Frontal plane deformity, transverse deformity. Get out of there. That's what we're trying to tell the body. Don't like it, decelerate it, get out of there. And again, we're getting the sagittal plane reaction we want. This is saying go here into deformity. This is saying go here into deformity. We're saying no, we're going to get out of it. So we get this going over our head a little bit, get that extension, get out of that kyphosis. Immediately I go, whoa, this feels great. Going down, up. You got it? Load. When it's load, I explode out of it. And again, when you kind of take me out of that, if I put this down, I take that down, take that weight off. If you don't have a scoliosis, those exercises done like that would give you a scoliosis. It's literally, I feel laterally flexed now to the right. I feel rotated to the left. Top down and bottom up, and I'm going, wait a minute, if I had a normal spine, I would have to do both sides of that, but because I have a scoliosis, lateral flexion to the right, to the left, apex to the right, rotation to the right, then that's exactly what I would do. Let's take a look, again, knowing that we can change the drivers now. We can use the free weight driver in the right hand, the bungee cord in the left. We can change a little bit what happens bottom up. Later on, we can actually apply a harness to the chest. I can apply a harness to the pelvis and create reactions I want based on bungees and based on weights. But from this, we have a really, really good foundation. My patient would do this every day. I'd try to convince them to do a component of this every day. I'd always want them to do mobility and then one of the stabilities, or mobility and a couple of the stabilities. Never just mobility and let it go. Mobility without creating stability is instability. And then I'm going to start throwing some other things in. So just for fun, let's think what we might do if we add a little ground reaction force, mass, and momentum with what we call a little bit of jumping jacks for a C scoliosis. Again, the one you're going to see now is for a right apex, lateral flexion to left, rotation right. If you say, again, mine's opposite, you're going to use exactly the mirror image. If you're going to do this for an S scoliosis, what we do for the hands is appropriate for the C scoliosis at the top to the right. If your S scoliosis, the C is to the left, you're going to flip it. And obviously at the bottom, if you have a C scoliosis to the left, you're going to flip it. If it's your C scoliosis to the right, you're going to do with what we're going to do with our feet in a jumping jack matrix in order to kind of make this a little more fun and show you all the other potential creative ways we can do to go after creating a new path to inhibit and hopefully and prayerfully prevent and get rid of and correct a scoliosis. This is a fun one to think through because, again, we're going to use jumping and we're going to use our ability to move across the ground to add ground reaction force, of course, gravity, and add mass and momentum to tell the curve that, hey, I know you like to go there, but when we load and explode, we're going to come out of there. So, again, that's key. We're going to understand that to facilitate this, both hands and both feet got to be doing something. If not, the body's going to bail out. So it's very interesting if I want to create what I call the reaction of the pelvis. It's very easy to do that. So if I want to elevate my left pelvis, I can easily just do a lateral jump to the left. Immediately you see that. My left foot hits, the left hip goes through adduction, this right side drops. If I want to then add more lateral flexion, top down, I can take my right hand and go over the top. And you're going to say, wait a minute, that's exactly what you would do in order to feed a C curve to the right. So we see a C curve to the right, I'm here, and all of a sudden, if you said, we'll do a little more of that, but as soon as you hit, if you explode out of that, you're going to say, let's feed the deformity and then explode out of it. So in the frontal plane, we already know what we're going to do. We're going to do some type of thing where I'm going to jump in the air and I'm going to go to the left, and I'm going to do something in the air. Well, when that same thing happens, I'm going to take my right hand and I'm going to drive my right hand basically to the left. And then saying, that's going to be pretty easy. Now, I also could take my left hand and bring it down and give me to the left just so I increase the curve. You're going to see we'll use our left hand in this case to create the transverse plane. Now, if you say, wait a minute, let me see if I understand the strategy here. As soon as you hit, you want to go deeper into the deformity. So the proprioceptors automatically say in that short period of time with all that extra stress, you want to come out of it. I bet you're going to take your left hand and rotate it right. So if I was jumping, hit, I'd come back out. Hit, come back out. Frontal plane, I would hit, come back out, hit, and come back out. Since I'm going to be bottom up in this too, I'm going to hit and come back out, hit and come back out. And you're saying, wait a minute, we got one more plane. The other plane we're going to talk about now is the transverse plane bottom up. So not only do I want to create this reaction, but I want to create this reaction. Why? Because relatively speaking, the pelvis is rotated left, spine rotated right, shoulders rotated left. I want to increase the deformity in order to explode out. So if I did something like this, here and explode out, here and explode out, here and explode out, my body would say, that's exactly what I want. In order to get that rotation to occur, I want to rotate along that posterior lateral angulation. Now, with applied functional science, we have the nomenclature for that. If I do a 2-footed jump left lateral, that's a left lateral angulation. If I do a 2-footed jump left posterior lateral, it simply means I'm going to go here. But if I add the word rotational, it means I'm going to actually get my feet literally along that angle, and I'm going to add a rotation to that, so I got this thing going on. So I'm literally going to add a component of rotation, left rotation, with my lateral jump. At the same time I do that, I'm going to take my right hand and go over the top. So let's just see how easy that is. So I got three drivers working, right? So I go here, boom, come back. Here, come back. Here, come back. Here, come back. And you immediately see this is sliding, deformity, and then when you see me explode out, all of a sudden you'll see my spine literally go deeper into deformity, but when I explode out, literally, subconsciously in an explosive, concentric way after an eccentric load, come out of that. And you already know I got to add one more plane of motion with my left hand. And that's simply going to be to add that component of rotation. So I'm going to go here and come back. I'm going to load and explode, load and explode, load and explode, and simply get this hand going. And I got myself a really cool scoliosis jumping jack. Kind of transverse plane of the feet, with a little bit of lateral translation, transverse plane of the left hand, frontal plane of the right hand, and it kind of brings a smile to your face. What kind of brings a smile to your face is if I have scoliosis, I know I'm doing something for myself. Plus, it's a lot of variety. Plus, you can tell that we can probably use our strategy to use our hands and feet a little different in order to facilitate that. So right now, if you were my patient and you had that C scoliosis, apex to the right, besides doing all the stability things we talked about and previously all the mobility things, every couple days I would throw this in and see if we could build up some endurance to the curve. And again, as you got really better, I'd have you go, excuse me, I'd have you go a little longer. I'd have you try to jump a little further, a little higher. And I might add some real light weights to actually give you a little more top-down kind of reaction. I could even add a little bit of ankle weight to the jump and to create a little different reaction to it. But again, our responsibility as the AFS practitioner is to watch their response. We're saying, I think that and that and that are going to load you, and I think when you come out of it, it's going to explode. It'd be very easy. Shirt off or halter top, take a little tablet, take a little phone, videotape it, slow it down and see, whoa, you're going in, but oh, look how you're coming out of that. And show the patient what good they're doing. Show what they're doing with their mobility. Show them what they're doing with the stability. Plus, they're going to learn the proper exercises and they'll know what they're going to be able to do at home. Plus, we'll have documentation of their successes. When you put all this together, we have to use our applied functional science mind, our applied functional science heart, and our applied functional science hands to create the best environments possible for that individual who has been somehow given this disease that we don't understand very well, but we do know it well enough that we know what we need to do to combat it, to give them every opportunity possible to come out of it and live a most normal life, as much normality as they can possibly get. And that's our responsibility to kind of think through that. Hopefully, these videos on scoliosis have created a foundation, a path for us to think on how to empower that individual to take advantage of AFS in order to ultimately enhance their life.